Italian time, so we are on time to get started. We will allow 30 seconds for everybody to join in, as it always good to do in this live events. You can also follow us streaming live from Facebook. And in 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Welcome everybody again to Food for Veins and Veins for Food, a not-for-profit humanitarian and top educational initiative that starts with the art of Monica Glovinsky, dedicated to the heart of the health professionals who have been involved in this COVID outbreak. That has, of course, led also to an economic crisis as reported by Lancet journal, a reason for which we decided to have this initiative that would have never been possible without the art and the expertise of true key opinion leaders from all around the world. You are seeing over here the pictures of the 23 ones who have been involved in a recorded video lessons in a dedicated platform you can enjoy also in the next days. Of course, it would have not been possible to report the 112 faculty members, equally stellar colleagues taking part in these live webinars that will be held during all the Sundays until August 23rd on all the major topics in venous and lymphatics, leading also to CME credits both at an international level and at a national level according to the different countries. The format will be always the same, 2 keynote speakers who needs absolutely no introduction considering their top quality. There will be always honorary chairs, and the honorary is because these professionals gave us the honor of recording the video lessons that I was mentioning and that you can enjoy in the dedicated page. They will give also the honor of wrapping up the concepts discussed during this webinar as a take-home messages at the end of these 90 minutes. But of course, not before having listened to the top expertise of equally great colleagues who are continental top experts representatives, in the sense that they will allow us to enjoy a scientific word round in 10 minutes. As you can see over here, for example, we have from UK to Asia to Latin America to Europe. And I'm sorry that Jean-Francois is thinking, je suis désolé. I'm sorry, Chris, but we know that Brexit is questioning now the boundaries as we were already doing before. So we have both UK and Europe. As always, nothing would have been possible without the support of all these stellar faculty members who volunteered for free to deliver their top expertise, individual donors, and the Magnificent Seven. So the different industries that equally supported this initiative, starting from Amnon, Balton, Bayer, Medi, Servier, Sigvaris, and Tatai. So deeply thank to all of you. We will report the results of this fundraising on October 16, the World Food Day. Of course, talking about food, it's not possible to forget the wonderful food moments we had together during social events, during the meetings. I hope that soon we will get back to normal and we'll have food moments together while we are supporting now for food projects. This has been our past and now present, and I'm sure that also in the future I will keep on traveling with these nice gentlemen who are like a family to me. So I will leave the microphone to Professor Bottini and then to Professor Chi. Oscar, the mic is yours. Oscar?
Here.
There are like some technical issues, Oscar, with your connection.
Yes,
Okay, we move to Willie and then we go back to Oscar. Willie, if you can say a word.
Yeah, well, thank you, Sergio. Thank you, everybody. Great world-renowned experts. I think this is a global event because as you can see from Sergio's map, every continent is represented with a different time zone. But it is certainly a pleasure and an honor to have the world expert to be with us in lifetime to participate in this humanitarian effort. Once again, I want to thank everybody for spending their Sunday morning with us, or Sunday afternoon or Sunday night, depends on time zone. Thank you all.
Thank you so much, Willie. Oscar, are you back with the connection?
Yes, I'm sorry, my internet was wrong. Dear friends,
Oscar? So while we are waiting for Oscar to fix his trouble, I will move forward. Oscar,
okay.
Are you here?
Okay, yes.
Okay,
yes.
Oscar, go.
Dear friends, being here today is my true honor and pleasure. It's a wonderful opportunity to be together with the most important experts and with friends from all around the world. The quality of the faculty and of contact is truly stellar. Even more in this difficult COVID time, it's stellar that we can be all together for showing the difference we can make in education and humanitarian support. Last but not least, as Latin American representative of this opening, I'm delighted to see a faculty covering all the nation of Latin America. A sign that once again, teamwork is the way. Also to enjoy the global initiatives for which I thank all attendees enjoy this online scientific trip. I look forward to be all together in person in Buenos Aires for next April meeting. Thank you.
Okay, thank you, Oscar. And then the last word of opening, we'll go to the guest of honor. You will see that in the next webinars also, we will always welcome somebody close by our ward, but not always like inside our ward. And in this case, it's my honor to introduce Professor Raquel Santiago. She's a professor of nutrition in Brazil. And I hope she is connected with us now and that she can give a word to all of us, because indeed this project, as you know, is dedicated to food support. So a word from the food ward to the Venous ward. Raquel?
Hello, everybody. Thanks, Sergio, for the invitation. And finally, today is the great day. Today, this initiative, wonderful initiative, Foods for Veins and Veins for Food starts with a mission to join efforts in such important field. We know that pandemic time reinforced the inequity and emphasized the increase in malnutrition. Without action, the world risks failing to meet the sustainable development goals and Paris Agreement. And we have the population with increasingly suffer from both undernutrition and overweight, including obesity and other diet-related chronic diseases. I hope that the next coming Sundays can be days for learning and discussing. And then at the post-pandemic time, new actors and new ideas may provide direction for cooperative efforts in order to minimize the inequities in food and health systems. Thanks again to be part of this initiative.
Thank you so much, Raquel, and all the food ward that has been working with us. And I'm sure that will be an increasing collaboration. So I ask now Professor Luri, who is the great kickoff together with Professor Glowinski. We start with Professor Luri with a big topic, the new CEAP classification. So I ask Khaled and Professor Luri to get ready sharing the screen and letting us starting this educational experience, starting really big, because we will talk about the new CEAP classification, new outcome measures in venous disease. So Fedor, can you hear us nicely and can you share your screen?
I am sharing my screen. It's just if the organizers can change the settings a little bit so I can see my slides.
Okay. And as I said,
that's okay.
We will enjoy 15 minutes talk by Professor Luri. Professor Luri usually does not need an introduction. Actually, it's my fault because I wanted to have a little bit of an introduction as well. So if you allow me, I will share my screen because I had a little bit of an intro for you, of course, because it's more than deserved. So if I can get to my presentation, one second. Okay. So can you see this? Can you see?
Yes.
As you can see, introducing Fedor Luri is like introducing Mozart. So all of us know him and the huge quality of his job. So I will just try to sum up 3 concepts. He is head at the Jobs Vascular Institute, and he has been a leader for many years of many societies, and we are all extremely close in the venous world to the American Venous Forum. And we always say, tell me who you are going with and we will tell you who you are. That's an Italian way of saying things. And Galina, many of us know her, and she's a wonderful person. So of course, also Fedor must be a wonderful person, as he will be a wonderful speaker, I'm sure, also in this talk. So sharing now the screen, Fedor, sorry, but I felt the necessity to introduce Mozart, even if everybody knows Mozart.
Yeah, that's very kind. I would start with congratulations to the Living Foundation for putting together such a wonderful humanitarian event in the program. It's a true honor to be a part of that. So thank you very much for that opportunity. Can you see my screen now?
I can see you,
yeah,
but not the screen.
Wait a second.
Khaled, can you enable his?
I'm not sure what's happening because I'm sharing my screen.
Khaled, you can jump in and...
I'll read that. Just one second.
Here we are.
Okay.
Here we are.
Can you see it now?
Yes.
Perfect. So my topic is the updated classification and outcome measures of chronic venous disease. My slides are not advancing.
Khaled?
Yeah, wait a second. Let me, okay. So let me see if now I lost completely my ability to advance slides, so I will, it would be nice if I can regain it.
Khaled, can you go back to his
presentation? You give me a control of my slides, because...
Khaled? Now it's moving.
It's moving, okay, so let me go back. Okay, perfect. Sorry about this introduction. So we all know that chronic venous disease has a very diverse manifestations. And it varies substantially among patients with a similar pathology, which makes clinical and scientific communication quite challenging. To address this issue, a standard classification system as the CEAP, CEAP, was introduced in 1996 and then revised in 2004. The aim was to provide a reliable and reproducible description of many manifestations of the chronic venous disease. The system is based on current understanding of venous pathology and natural history of venous disease, which obviously changes over time. I think I can see that now. Introduction of CEAP classification has simplified evaluation of various treatment modalities, allowed comparison results from multiple institutions, and also enhanced our understanding of venous pathology. I'm not advancing my slides. I apologize for that. Can I go to the next slide, please?
Khaled? You were advancing before.
Well, I did advance before. Okay, perfect. So now I can do it now. So thank you. Because of the introduction of CEAP classification, quite a few studies become possible. It was possible to conduct large epidemiological studies. It was also possible to develop practical guidelines that are systematic and standardized here across the system. It took about 7 years for CEAP to become widely used. By that time, and in large part due to utilization of CEAP itself, accumulated evidence required a revision of this classification. Now you can see that it took another 7 years until the revised classification became a standard. Understandably, the publications continue using the old version for some time, while practitioners become familiar and start using the newly revised version of classification. Keeping this in mind, the task force that was created by the American Venous Forum in order to align CEAP with our current understanding of chronic venous disease adopted 4 guided principles, of which 2 first were aimed to decrease this adaptation lag. The task force was structured to address the 4 components of CEAP and ensure the continuity of CEAP process. You can see it was truly international effort by a group of top experts in venous disease. CEAP is essentially a consensus document, and so the modified Delphi methodology was adopted through this process. It took about 2 years to develop that document, and it is now published and available at the Journal of Vascular Surgery of Venous and Lymphatic Disorders. The updated CEAP remains to be a descriptive classification. It describes the symptoms and symptomatic status of each limb of a patient at a point of time. It is not designed and should not be used as the assessment for severity of the disease or assessments for treatment outcome. The updates in the classification were limited to what can be supported by a reasonable level of evidence, and I will address separately the issue of complete versus abbreviated CEAP. Briefly, the updates include adding modifier R to cases of recurrent varicose veins and recurrent ulcerations, adding phlebectatica to C4 clinical class, separating intravenous and extravenous causes of secondary chronic venous disease, and replacing the numbers with abbreviations for venous segments. Although the signs are the same, the history of previous intervention changes the dynamic of the disease and the treatment options, which was the reason to add modifier R to denote recurrent varicose veins. It's worthwhile to mention that C3 clinical class describes edema caused by venous disease. A patient with lymphedema and no chronic venous disease should not be classified as the C3 clinical class. Phlebectatica depicted at the slide has natural history that is different from such in C2 patients. There is some evidence that it increases the risk of ulceration and increases the risk of progression to more advanced stages of chronic venous disease. A new position of a lag with phlebectatica, now it is C4C. Recurrent ulcerations has also been shown having different natural history compared to the first episode of an ulcer. It is now described as C6R. Here is a summary slide for updated clinical classes. You can see in red the updates, and the gray, the remaining segments of the C part of the CEAP. A difference in natural history and treatment option also prompted the task force to separate intra and extravenous causes of secondary chronic venous disease. Finally, using common abbreviation for venous segments should simplify the use of CEAP in clinical practice. Although not a part of CEAP 2020, I would like to emphasize the importance of using a complete CEAP, but not abbreviated. All 3 of these lags could be classified the same as C5 clinical class. However, each of them represent a very different clinical scenario. The first patient has symptomatic varicose veins, inflammatory skin changes, and healed ulcer, C2, 4A, 5S. However, she has only primary disease limited to reflux in the great saphenous vein. You can suggest just from that description that this patient may have indication for great saphenous vein ablation. The second patient also has skin changes and healed ulcer, but he is asymptomatic at this time. He has secondary CVD caused by intravenous causes, specifically obstruction of femoral and popliteal veins. You know from that complete CEAP description, the patient does not have superficial reflux, nor does he has iliac vein obstruction. The third patient has C3, swelling, 4A, inflammatory skin changes, and 5, healed ulcer. She is symptomatic, S. She has secondary disease with extravenous causes, obstruction of the common iliac vein, which is basically a May-Turner syndrome. A complete CEAP gives you all this information that otherwise would be missed. As I mentioned before, CEAP does not assess the severity of the disease. The VCSS is an instrument that is designed to do that. It also has recently revised and showed very good reproducibility in clinical use. It has 11 categories, each of them graded from 0 to 3 in severity. The total VCSS score ranges from 0 to 33. In this example, we have a patient with clinical class 4B. He has occasional pain, diffuse skin pigmentation and induration in the lower leg. He has no swelling or ulcer and uses compression only when he is symptomatic. His total VCSS is 6. In contrast to C4B patient with VCSE score of 6, here is a patient with C2 clinical class with varicose veins in the calf and thigh. She has daily pain and need to take frequent breaks to elevate her legs to relieve this pain. She regularly uses compression stockings, which helps her to manage her symptoms and to go about her daily activities. Her VCSS score is 9. These two examples illustrate that CEAP is not a severity measure. As you can see, C2 patients can have a much more severe disease than C4 patients. C5 patients can be completely asymptomatic and fully functional. To conclude, we have two standard instruments, CEAP classification to describe a lower extremity of a patient at a specific time point, and VCSS to measure the severity of the disease. Both of them should be used simultaneously. And I thank you very much for your attention, and thanks again to the Foundation for putting together such a wonderful humanitarian event.
Thank you so much, Peter. It would be wonderful to applaud you because in reality, we are 614 people live who have enjoyed this talk in Zoom, plus all the other ones will be on Facebook. So I expect we are more than 1,000 people really listening to your talk. I'd like Khaled to allow me to share my screen now so that we can move forward with the program. So you should be able to see my screen now. Are you able to see that?
Yes.
Yes, that is great. Thank you. So we will now move according to the plan to the 10-minute scientific word round, thanks to the, let's say, bullet questions we will have from the top experts representing the different continents. And of course, in this case, there is no North America because we had Fedor as representative of North America. So I ask Chris Latimer, we are going in alphabetical order from the Imperial College of London, another top expert who needs no introduction, to give us the question he has for Fedor. And we can stop sharing mine, Khaled. Chris, you should be here.
Okay, can everybody hear me?
Yes.
Yes.
Thank you, Sergio, for my 1 minute. I will just use 1 minute. And thank you, Fedor, for an excellent comprehensive summary. You mentioned C3, 4A, 5SE, SEA, EIV, P naught or 0, PO, to justify the importance of the CEAP classification. I mean, as you know, in the UK, in reality, we don't really use CEAP for day-to-day management. We prefer to use words instead of long alphanumeric characters and strings like residual veins and mixed ulcer. And in your prevalence slide, CEAP slide, on C1, there was 59.1% from the Bond vein study and only 16.5 in the Polish study. That's a big difference. And on your images on C1, perhaps that should be a C4C, using your stated definition of corona, and your C2, perhaps that should be a C3, giving the fullness and thickening in the gator region characteristic of venous disease. So my question, is there any place for CEAP now in day-to-day management when we can use words instead, and in a research setting, can CEAP actually be harmful because of its clear lack of precision and great variation? You asked me to be controversial.
No, that's what it is. And indeed, we are all among friends. And it sounds a little bit like Brexit, but it's a great question.
That's probably part why Brexit happened. Well, Chris thinks it's a fantastic question. Well, if you want to write a page, you can write a page. If you want to write just one line, you can use CEAP. It gives you exactly the same information. You don't need to read it aloud. This is the information that you can just put underneath the picture, and I will know about the patient exactly as much as you will write 2 or 3 pages describing that. That's the whole purpose. Now, the second part of your question was regarding reliability. That is really tightly connected to the universal use of the standard definition. The more standards are definition, the more reliable will be a classification. So those connected, but not necessarily the same issues.
That is fantastic. So let's move forward now. We fly from UK in alphabetical order all the way to Malaysia with Professor Liu from Putra University, another top experts. Needs no introduction, involving many guidelines. So NC, would you please make your question to Professor Liu?
Thank you, Sergio. I hope you can all hear me.
Yes.
Yeah, Fedor, that's a very nice lecture that you gave. It's very comprehensive and very clear. My question is, in Asia, up to about 50% of our patients presents late with C4, C5, and C6. And some of them present when they have complications. So when a patient comes in with, say, bleeding or maybe phlebitis, now how do you classify them?
That's absolutely fantastic question. I really appreciate it, because the CEAP classification really focus on primary manifestation of the chronic venous disease, not on the complication. And acute phlebitis or acute thrombosis is not a part of chronic venous disease from that perspective, but it is true. I really don't know how to answer your question precisely, because I only have 3 minutes. It's probably going to be a next step that we need to establish, how to improve CEAP to include those acute events as complications.
Okay, so we should have now Willie introducing the next. Willie?
Yeah, so our next panelist is again, without a need for introduction, the great Dr. Roberto Simkin from Argentina.
Roberto,
you want to go and ask your question?
Roberto,
Yes,
can you hear me?
okay.
Yeah.
Yes, okay. Congratulations, Professor Luri, for the excellent presentation. I have a question. Let me know, what are the criteria to include the phlebectatic crown in C4?
So the corona phlebectatica, thanks, first of all, Roberto, thank you. It was a contentious issue through years. I think we had, first, the idea was introduced at the UAP Congress in Rome, years ago. And at that time, the argument against that was that we have no evidence of difference between the corona and other stages. Now we have at least 3 publications that all of them are consistently show the same, that corona phlebectatica has different natural history and increases the risk of progression of venous disease. Now, you can argue, of course, about small studies, but they're very consistent. And using those studies, we concluded that it's appropriate to put corona in the 4 class. However, because we need to preserve the previous classification, so it will be no mixture, it put into 4C, so that we preserve the definition of 4A and 4B.
That is great.
Thank you.
We are checking if the connection of Oscar is good from Professor Bottini. So if he's live and he wants to introduce the last question from France. Okay.
Let me introduce Dr. Ull. Professor Ull is participating in our committee in the UAP, in education committee. Then Dr. Ull, please.
Jean-François, can you hear us? Jean-François Ull?
You want me to talk?
Yes.
Yes. I have a question. I have a remark and a question for Fedor.
Just a question. Just a question. No remark.
Of course, everybody knows.
Okay.
Talk.
Jean-François? Connection is bad, very probably. So we move forward and we will go back to Jean-François. Jean-François, can you hear us? Meanwhile, we are checking out Jean-François. Yes. Okay, Jean-François, go.
I have a remark for...
no, you can...
No, I like very much corona, not virus, corona. I like...
Okay, so Jean-François, unfortunately the connection is so good that not even Professor Luri can answer to a question he cannot listen to, I think. So I suggest you write that, and this is a reminder for everybody. You can write in the question and answer box your question. And we will reply, if not live, also in the next days, and you can do that in the different languages. So please use question and answer function so we can trace. So we will check also on the chat, but please use the question and answer. Now we are perfectly on time to move to the open question, where everybody from the 616 attendees I see over here, plus the panelists, plus I think the other hundreds of people that are live on Facebook. So it's really quite the first time for me to face more than 1,000 people together. So Fedor, you have quite a lot of pressure. I've never seen somebody answer to 1,000 people. So if you can answer to the first question that is coming directly from Egypt, Fedor, from Professor Ta, another big expert who needs no introduction. She's writing, excellent presentation, Professor Luri, congratulations for new CEAP. My question, corona phlebectatica classified C4C means more aggressive compared to lipodermatosclerosis, Fedor?
No, I partially addressed this question before, but let me make sure once again that the CEAP classification is not designed to measure severity. So it doesn't matter that, doesn't mean that C4, for example, is more severe than C3. Now it can be perceived that C4A is less severe than C4B, or that's not true. In many patients, C4B can be less severe than C4A. And so the position in the CEAP classification does not reflect the severity. The reason why we denote it as C4C is to preserve the previous 4A and 4B descriptions. So we can retroactively classify patients that were C4A and 4B using this classification exactly the same.
Thank you, Peter. So we are moving to the second question. If Jean-Francois has no connection. Jean-Francois, do you have connection?
Very sorry, my
No. Yeah, if you want to.
Connection is unstable. So yes, I have a remark and a question for Fedor, of course, because I like very much corona, as you know, not coronavirus, but corona phlebectatica. And corona is a very important sign. And everybody knows corona phlebectatica, but it's not very easy to make the diagnosis in clinical practice. There's a lot of different details, and so I think that it would be nice to explain more in detail what is corona in a clinical practice for people, because it's so important, because it's a very it's a predictive sign, very significant predictive sign of the occurrence of skin changes. So in a simple clinical sign, if you can make the diagnosis, it's very powerful because it's very simple. With your eyes, in half a second, you have the diagnosis, and you can say this patient should be treated. So I think it's very, and for me, it's the most important modification, improvement, refinement of the CEAP classification of the last session of the CEAP classification. What do you think, Fedor? Useful to explain what the corona is, and examples for people, for practitioners?
Peter, are you able to answer with the limited
Yes,
words?
absolutely, Jean-Francois. It's an excellent point, and as a matter of fact, we are working right now on writing the clinical examples to help the practitioners to identify each of the classes. This would be very, very important. Just use this opportunity to address, you were actually one of the co-authors of the study that look at reproducibility of corona phlebectatica in clinical use, and show that its reproducibility is actually pretty high. Right. So that was one of the factors why we decided that it's time to include it in the CEAP.
Yeah, sure.
Okay, so we move forward with the question from Denis Borsuk from Russia. He's asking why Fedor didn't say about, I'm reading the text, why didn't you say about a huge advantage of the new CEAP that is now the anterior accessory separate from GSB? So he's asking basically to stress out the separation between anterior accessory and great, and why didn't you dive a little bit more into that?
Just because I didn't have time, but I can agree that that given the anatomical abbreviations instead of numbers create a lot of flexibility, and I don't know which veins will be perceived more important 10 years from now, but that will not prevent from including them in the CEAP classification anymore.
Okay. And we will take the last one, and then again, I know Fedor is a real gentleman, and I'm sure he will be available in the next days to have a look together at all the questions you received and maybe address them, and we will reply. So we will stop in Egypt with a quick one and quick answer. Ahmed Hussein, Professor Hussein is another big one. Great presentation, Professor Luri. Any duplication of description you observe when we look at CEAP and VCSS, especially when we focus on C5 and 6 patients? Do you recommend to always use both grading systems while reporting each case? Fedor, did you get me?
Recommend to use both systems, yes.
Yes.
That's the answer is yes.
Okay, that is great, and it's 4:39 over here in Italy. And I truly wish we could upload you in 632 people plus other 18 panelists plus all the other ones. This is why you really demonstrated you are Mozart in this scenario. Thank you so much, Fedor.
Thank you.
Now we move, and if I can share my screen, Khaled, we move now to the following part of this webinar. And if I introduced before Mozart, now I have to introduce, of course, Beethoven, because Professor Golovinsky is another one that for sure is one of the giants of our field. He's from Mayo Clinic, as we know. So I try to sum up a never-ending curriculum in just in 3 points, as I did before. So Mayo Clinic, of course, needs an introduction, and he has been one of the heads of that place. You see Beethoven is writing over there because indeed Professor Glowinski is editor-in-chief of the Journal of Vascular Surgery journals, and he's also spending his nice time with Monica Glowinski, that is a living proof that he's a nice person as well, let's say. So I stop sharing my screen, and I will let Peter joining us and sharing his screen. Peter, are you with us? Peter?
I am right here.
Yes, I was worried you are with Monica enjoying a coffee. So Professor Glowinski will talk about practice guidelines, critical use, and appropriate use criteria for best venous outcomes.
Thank you very much, Sergio, and good morning, everybody. It is 10 o'clock in the morning here in Rochester, Minnesota. First, let me tell you how pleased I am to be a part of this presentation. It's a true honor to be invited for such a noble cause, really, to bring together venous education and our fight for starvation that's due to the COVID-19 pandemic. I'd like to use my time to talk to you and help you, hopefully, with the critical use of the ever-increasing number of practice guidelines and now appropriate use criteria to assure the best venous outcomes. We need trustworthy guidelines, and to have great guidelines, they have to be based on scientific evidence provided by systematic reviews and meta-analysis. Guidelines are actually a set of recommendations for my clinical practice. It considers alternative managements in diagnosis and in treatment. Should we do A or should we do B? And most importantly, it compares the benefits to the harms. And that's how guidelines make recommendations. There are now great instruments, improving instruments like the AGRI-2 instrument that actually can tell us if a guideline that we deal with is a good guideline or something that we should not trust. I mean, a great guideline defines the scope and purpose of the guidelines. It tries to include all stakeholders, not just surgeons, not just radiologists, but in our case, everybody who deals with treatment or delivery of care of venous disease. It's very important that guidelines are developed based on a rigor that is scientific and well described in numerous documents, that it is clear, it's applicable, and most importantly, the funding agencies are separated from the authors. So there is an editorial independence. What are we looking for? We are looking for scientific evidence. What gives us the best scientific evidence to write our guidelines? It's meta-analysis and systematic reviews of great, large, randomized controlled trials. We are learning more and more from prospectively corrected registries, which are important because it incorporates not only carefully selected patients of a randomized control trial, but it really incorporates our everyday practice. And obviously, all other type of scientific research are important, but they have less evidence to support a recommendation. The PICO framework came in not very long ago, and we are going to use it for our current update of the varicose vein guidelines of the American Venous Forum and the Society for Vascular Surgery. And it is actually a very clear description of what we are doing to come to a single recommendation. We define the patient population, like C2, simple varicose veins. We pick an intervention, subvenous ablation, and we compare it to another intervention like compression. And then we decide on outcome, quality of life, benefit for the patient, harms of the treatment, as I mentioned before. And then we make a recommendation that is graded. And that is very important, because when you read a recommendation, you don't follow that recommendation blindly. It is very important whether it is a strong or a weak recommendation, whether that recommendation is based on a low level, moderate level, or a high level of evidence. And there are different type of grading systems used for guidelines. This is the one that we used most frequently for AVF SVS guidelines, and also for the Handbook of Venous Disorders, where we try to summarize the American Venous Forum guidelines. And you can see the grade of the recommendation can be strong and weak, and that is a little bit the enthusiasm of the writing group. And then the grade of the evidence can be A, B, and C. And again, in case of any guidelines you read, immediately look at the lower right or left corner. Is it strong? And what is the quality of evidence? There are great guidelines on the management of varicose veins coming from, I believe, this side of the continent, and then also, obviously, the European societies and the national clinical guideline centers that Professor Davis initiated. And then we also have our handbook of our society that lists now 300 clinical practice guidelines on venous and lymphatic diseases and on other venous and lymphatic pathologies. Fedor presented us the reporting standards. It is so important that all these guidelines that you've seen, they use the same reporting standards. There is finally a unified classification. And you can call it, Chris, ulcer, you can call it simple varicose veins. You don't have to say C6, all right? I mean, I go with that. But you should know what is a disorder, what is a disease, and what is chronic venous insufficiency, because that puts the whole decision and recommendation into a perspective, you know? When we use recommendation for simple varicose veins and we are telling to everybody that this is advanced chronic venous insufficiency and 40 million Americans have advanced chronic venous insufficiency, well, we are not talking about apples, we are talking about apples and oranges. So I think this is great. If any of you have not read the updated classification, I'm sure that now after Fedor's presentation, and if you watch this presentation, I just would like to call your attention that it is online and in press. So what do guidelines use? We use randomized controlled trials, but we use them critically. I mean, we are basing on recommending intervention versus conservative management on the reactive trial, which was a good trial. It was, it really showed that at 2 years, surgery was superior for symptomatic relief, cosmetic results, quality of life, and even it was cost effective. But again, this is a great study on high ligation stripping and phlebectomy, but does not necessarily show all current new technology that performs likely the same way as surgery, but still, when we graded this recommendation, we graded it as a level B. And the recommendation is that we recommend against compression therapy as the primary treatment of symptomatic varicose veins in patients who are candidates for venous vein ablation. But it was a strong recommendation because we all felt that patients should not wait 3 months, as insurance companies tell us, because if they are ready for an intervention, they should undergo intervention. Now, recommendations change as new information comes up. And that is also very important. You should follow the guidelines, but you should know the date when this guideline was written. And if the literature has new information, that guideline may not be good anymore. The SCAR trial, which was first authored by Manchkol, really gave us excellent data on the effectiveness of compression to heal ulceration. And that at the time we wrote the guidelines, it was a 1A recommendation. Compression was the primary treatment of healing venous ulcers. Well, he came up with a second study. And that second study, the EVRA, actually showed us that that's not the case. Early intervention is beneficial. So in the updated guideline, clearly that's going to be reflected. And now we recommend compression therapy and early endovenous ablation within 2 weeks as the primary treatment. So it is a 1A recommendation. Now, let me tell you a little bit about appropriate use criteria, because we just published in the Journal of Vascular Surgery an excellent document that you all should consult. The appropriate use criteria that has been around for 10, 15 years is now really used with increasing frequency to really try to use it for indications of cost-effective care. But at the time the Rand Corporation designed this manual and came up with, it was really based on the concept of appropriate care and necessary care, with the goal that not patients receive not only appropriate, but those patients who need care, it is well defined for them what the necessary care is. So actually it aims to prevent inappropriate overuse or inappropriate underuse, both of the procedures. It is interesting that it's not just based on evidence. It combines the best available evidence with the collective judgment of experts. And that's why we need it, because we have so many innovations in venous surgery, because appropriate use criteria can set up or give us guidance to recommend innovations and new treatment, even if robust scientific evidence is not available, because it takes into account the opinions of experts of your specialty. CMS, which is the Centers for Medicare and Medicaid Services, now developed a program, and again, primarily for reimbursement, but also to define the best possible procedure, diagnostic or therapeutic. It requires that it is a national professional medical society or a medical specialty society, or what they call a provider-led entity that comes up with the document, and it helps physicians make the most patient-appropriate treatment decision. And to the extent possible, obviously, these criteria must be evidence-based. So for appropriate use criteria, there is an expert consensus, and there is the evidence from RCTs, systematic reviews, meta-analysis. Now, the expert consensus, you would think everybody has to agree, which is true, but not at the same level. And this is how appropriate use criteria are done through a process that is well described in this document and also in the manuscript, in the excellent manuscript of Elna Masuda. So the expert panel rates the indications and then gives you the criteria. And again, you should know that even if a procedure is inappropriate, maybe 1/3 of the experts voted for it. So there is an agreement to proceed with a recommendation, but the consensus is actually, can be at different levels depending on the participants. This is the document. It is now available online and it's going to come out actually in the next issue of the Journal of Vascular Surgery. This document is interesting because it added the never appropriate category, which was a unanimous agreement of never to do a procedure for that certain indication. And just a couple of examples quickly. One is obviously there are clearly evident appropriate procedures, the CEAP 2-6 classes with axial reflux, with or without saphenofemoral junction reflux, small Swain, appropriate recommendation. Now, here is some example of what's rarely appropriate or never appropriate. It's rarely appropriate for therapeutic reason, not for clinical, for cosmetic reason, for therapeutic reason to treat asymptomatic C1 or 2 disease. And it's never appropriate according to the 16 experts when there is no reflux. These were just the recommendations, a couple of examples on perforator vein treatment. Appropriate if you have advanced disease, rarely appropriate in C1-2 if there is high outward flow, large diameter perforator directed towards the affected area. It might be appropriate, but in asymptomatic patients, you should not treat perforators. And then finally, for stenting, it's always appropriate to treat for advanced disease. It may be appropriate in patients who only have edema, but as Fedor mentioned in C3, you can have edema for other causes, and you should always exclude non-venous causes of lymphedema. But it is never appropriate to do a patient with May-Turner syndrome that was an incidental finding by imaging. So again, read this document. The conclusion is very important because it is important that it is a guide to patient care, even if high quality evidence is not available. It is really supposed to describe practice pattern and not the final treatment decision of an individual patient, because then individual cases can differ from that. But if the practice pattern of that physician reflects inappropriate delivery of care, that's going to show up. And obviously it helps physicians and stakeholders to improve patient care and identify the priorities of future research. So to sum it up, how do we manage our patients with chronic venous disease in 2020? We have two important part of our decision-making process that's going to guide us, the clinical practice guidelines, the most recent, and the appropriate use criteria. But again, the final decision boils down to the physician, the physician's clinical experience, and obviously to the patient. The patient's values and preferences needs to be honored and taken into account. And as I'm sure Professor Davis is going to talk maybe more about this, cost effectiveness is important because in some systems, that has a major effect on how treatment is delivered to our patients. And once we take all this into account, then we can come up with the best treatment of patients with chronic venous disease. I'd like to thank all of you for the opportunity to present this data, and I'm happy to discuss any part of this presentation.
Thank you so much, Peter. And you have 667 people uploading you, plus all the live ones. I will share my screen. Khaled, please allow my share screening so that we can move forward with the presentation. So give me 1 second. We will now start the scientific word round in 10 minutes, and we will start from Europe with University of Porto, Portugal. No needs of introduction for Professor Armando Mansilla, editor of the International Angiology Journal. So Armando, if you can hear us, please go with your question.
Thank you, Sergio. Welcome to everybody. Well, Peter, thank you for your outstanding overview as usual. And Sergio asked me to put you a 1-minute controversial question. And my controversial question to you, it is concerning the reading of the guidelines. We have guidelines from international societies and guidelines published by the national societies. What can justify having different levels of evidence and grade of recommendation for the same question, using the same system to establish these levels, when you read the North American guidelines, the Latin American guidelines, and at Europe, at least you have 2 from European Society for Vascular Surgery and from European Venous Forum. My apologies for this question, but my point is, are you talking really about the published evidence, or are we talking also about the interpretation of the evidence by the different scientific committees of these societies? Thank you.
Well, that's a wonderful question, and it is true. And I think in some way I try to point out that it is very important when the guidelines are written, what is the evidence that's available at that time. Sometimes printing the guideline takes a year. Certainly in the previous years, now everything is online. It's a little bit easier, but it is very important to see the list of references of the guidelines. And I think that is the first thing I would do. The second is indeed, and we have now increasing number of publications qualifying the different type of guidelines, and we have one coming up from Professor O'Donnell and also from Alan Davis's group on defining the different type of lymphedema guidelines and pointing out the problems. And that's why I think using the AGRI-2 instrument to really tell us that this guideline is a high quality guideline that we can trust, that's important, because there are so many reasons why guidelines can be influenced by the number of and the type of stakeholders available, by funding agencies and all kinds of things. So it is not easy. I think it is our responsibility to bring together all venous societies to come up with the best possible guidelines that is continuously updated based on the available evidence.
Thank you so much, Peter and Armando. Now, Professor Bottini, Oscar, would you like to introduce the next?
Okay. Before Sergio, please, I have a question with Peter.
I'm sorry, it's not allowed. I'm sorry. You will have to do that later on. It's against the rules. I know you're important, but you cannot break the rules. So please introduce the next speaker.
Okay, perfect.
The next discussant.
Let me introduce Professor Pittman from ABLS. And Professor Pittman.
So Chris, can you hear us?
Yeah, I can hear you fine. Thank you, Oscar and Dr. Glowacki. Fantastic distillation and discussion on guidelines and appropriate use criteria. Since patients are the only stakeholders we should actually focus on, I'm wondering what your opinion is on a patient-reported outcomes only guideline. I'm a policy expert. That's the only reason I'm here.
Not true. Not true.
And I interact with the federal government, state government, commercial insurers, Medicare, and at the end of the day, they only care about what helps patients. Payers and patients care about what helps them. Shout out to Dr. Mark Garcia, who asked the same question. Why shouldn't we be focusing our guidelines on patient-reported outcomes only? Thank you.
Very important question. Thank you very much, Dr. Pittman. Patient-reported outcomes are important. Patients' opinions is important. Public opinion is important. So what we do, and I know that the UK guidelines and many of the other guidelines are using this process as well, that before we publish anything, we put it up for public comments. We actually try to invite patients to participate, and certainly deciding on the right outcome measures, patient-reported outcome, quality of life, disease-specific instrument use in guidelines are becoming extremely important. So thank you for emphasizing this aspect of the guidelines, because we clearly should go into that direction.
And I deeply thank Chris that even if he just delivered the fake news, because he's not here just for his political expertise, but also for the wonderful contribution he's giving inside the AVLS and in science in general. Willie, it's your time to introduce now the expert discussant from Latin America.
Yeah, well, I want to introduce my good friend and the author of the new paper, along with Fidor, Dr. Fabricio Santiago from Brazil.
Hello, everybody. Dr. Glowicki, excellent presentation. I'm going to address a question regarding the recently published AUC document published on GFS. From a practical perspective, it's terrific indeed. And it also addresses the to individualized patients. Okay, but there was a replacement. The original method from RAND, from the lowest scoring point, there's the procedure is considered inappropriate. There was a replacement to never appropriate. So I would like to ask you, why was that done first? And if you don't think that this could be a powerful weapon for lawyers, for an example, if you individualize patients and the lawyer has on his hands a document stating that that procedure was never appropriate at all. Thank you.
Excellent question, because it is a clear difference of the varicose vein guideline from the RAN Corporation recommendation. It was debated numerous times during our deliberation, both the writing committee and the scientific panel. Ultimately, we believe that we are not writing a legal document, but we wanted to emphasize a unanimous agreement of the 16 panelists by designating one portion of the inappropriate treatment never appropriate. So this is a legitimate question. It can be a potential for debate, because in this form, the instrument became a little bit unvalidated, because the original validated instrument was, as you correctly mentioned, the RAND Corporation categories. I think we just felt as a society and as individuals responsible for venous disease management in the United States, that the inappropriate increase of venous procedure in some areas of the country is so unacceptable for us that we wanted to voice our concern.
Thank you so much, Peter and Fabricia. Now we fly all the way to University of St. Petersburg in Russia, and we have Professor Shaidakov, another giant who needs no introduction. So Eugene, are you with us? Can you hear us and make a question to Peter?
Yeah, Peter, thank you very much for your presentation. And hi, everyone. Congratulations for interesting session. My question is related to the question raised to Armando, which means that we are not only friends and think the same directions, but that many physicians may see the same issues related in guidelines. In daily practice, we rely on clinical practice guidelines. There are different guidelines from various societies. Interestingly, there are the discrepancies between them, despite the fact that they should be based on the same published evidence. The actual content of the guidelines apparently depends on the whole team that work on the document. And it's a great honor and responsibility to be a part of such a team. Peter, what do you think should be the requirement to the specialists who may be included to the guidelines writing group? Personal experience in research, actual clinical experience in the field, lack of conflict interest, or altogether? Thank you.
Evgeny, spasiba. So
I know that you know Russian perfect.
So to tell you the truth, everything that you mentioned are important. And to me, conflict of interest is very important. And obviously, the chair of the committee should be free of conflict of interest. And in the United States, 50% of the authors should be free of conflict of interest. Expertise is important. Methodologist is important. So it is a combination of several things, as you mentioned, that needs to be taken into consideration. And even if you have all this, I am the first who tells you that there are differences in availability of technology in different countries. And just, for venous disease, obviously hard to write guidelines on using technology that's not available in one country. So I think it ultimately boils down that international or national guidelines taken over by your society has to be broken down and interpreted by the expert panel that you designate. So it clearly is important that national interest, availability, and national values preferences are taken into account.
Thank you so much, Peter and Eugene. So now we move forward with the open discussion. So I invite everybody to write. And again, we are more than 1,000 people. So I would suggest to write and be sure, knowing also Peter is a true gentleman as well. So I'm sure that he will be available in the next days to eventually review the questions and answer. Peter, can you hear us? Because you're freezing a little bit. Can you hear us, Peter?
Yes, I can hear you.
That's great. So I'd like just to take some of the questions from all the audience, and in honor of all the ones who are listening to us in pyjama, because it's very probably already extremely late over there, we go all the way to Singapore to Professor Sriram Narayan, a big expert as well. He's asking, when does a patient's views, expectations, ability to tolerate symptoms come into play in the PICO-based recommendations, Peter? Did you get the question?
Could you repeat? Could you repeat it?
Yes. When does a patient's views, expectations, ability to tolerate symptoms come into play in the PICO-based recommendation?
Well, clearly, symptomatic patient is with the appropriate pathology deserves treatment. And it is the patient and the treating physician who has to make the decision whether those symptoms warrant an intervention or not. So again, it's a local discussion of the risk and the benefit. That's the way I see it.
Thank you so much. And since I feel really guilty that I shut it down before Professor Bottini, Oscar, would you like to make the question you were looking for before?
Yes. How do you measure the cost effectiveness in the recommendation in relation to different countries, different cost, different situation? How do you measure? How do you measure?
I think it is an excellent question. I would like to point out that cost effectiveness specifically has not been measured in the United States guidelines. So knowing very well that Alan Davis is going to summarize it, I will ask him to really, guide us, because the UK NICE guidelines are based on cost effectiveness and nothing else. The RAND Corporation Appropriate Use criteria makes a point that you have to decide on the most appropriate treatment, exclusive the cost, So again, we probably are not advanced enough to make recommendations, but we have not done thorough cost effectiveness analysis in our guidelines. So I leave it up to Alan to comment on that.
And since we will move to Alan in a second, I'd like to take this huge chance to ask you and Fedor, since we are really interested in guidelines, that last year we did these similarities and controversies on guidelines document. My question has always been, how do we select these experts? I know that according to the Delphi methodology, there is a process. But in reality, an expert can be a huge academic with no practical expertise and vice versa. So do you have any insight? Because that could really change the recommendations when we are doing these Delphi. So do you have any tips and tricks on how to properly, define an expert?
You need a mix of the people who are practitioners, who are academicians, who are methodologists, and who are also largely free of conflict of interest. So I think this is a potpourri of the different type of experts, and then also representatives of all the stakeholders.
And since we have the honor, over here of having you from Journal of Vascular Surgery, Armando Mancilla from International Angiology, Professor Davis from phlebology, and we have demonstrated also after the V-Winter meeting last year with the document that 1 recommendation out of 5 gets outdated in 3 years. Do you think that as journals we should move to an online platform, have a constant adaptation based on the evidence-based data, like a little bit in NICE, or should we still focus on all the long editorial part?
Well, again, the NICE has a very specific purpose: cost effectiveness within a single-payer system. That is not applicable for the United States. That's why you will find resistance. So I think it is good, as we have done, to bring together all the societies, but then we have to all agree that we follow clearly an instrument like the agreed to guidelines, and we put together our committee based on the highest level of scrutiny to come up with a group that can make recommendation that is free of conflict of interest.
Fedor, do you have any comment as keynote speaker of the session? Fedor?
Well, I think that Peter made a perfect description of the expert. The only thing I can add to that is you have to define ahead what you're looking for. And if you're creating a consensus document, and you have to define what would define the expertise for that particular segment, because the guidelines and consensus documents are very different in their aim, and so the expertise of the panelists should match that specific aim of the document.
Okay, thank you so much. So we move toward
Sergio, can I just ask a question?
I'm going to introduce you, Prof.
I just wanted, before I do that, can I just ask Peter a question?
Yeah, sure, absolutely.
Peter, I'm very interested by your statement that in America, you, in a way, don't think cost effectiveness is important, when your own AHRQ very clearly mandates that you should be looking at cost effectiveness, and that is how healthcare spend should be determined in the US. So I wonder if you would like to comment on that.
Sure. I mean, it is important. What I wanted to say is that we have not dealt with cost effectiveness and cost effective analysis with the type of scrutiny that you did in the NICE guidelines. We did not do that. And even if our current update, it's not going to be that detailed like you did. So yes, and what I was actually saying in my presentation, that the appropriate use criteria right now by the CMS is used to assure cost effectiveness, because when you order a test in the appropriate use criteria, it has to be an appropriate category. Otherwise, they are not going to approve the test. So I think, yes, you are right. It is heading in that direction, because I mean the money that the United States and all the countries, but United States spends the largest amount of money on healthcare. So it is important, and I think I'm sure that in the upcoming guidelines we are going to see more cost effectiveness analysis, as you did.
Okay, thank you so much. So let me share my screen for a second so that I can properly introduce Professor Davis, because of course we are talking about giants also in this case. Indeed, if we talk about Mozart and Beethoven before, you see over here Riccardo Muti, for the ones who are loving opera, is a huge opera director. So Professor Davis is, as we all know, from the Imperial College London, is the editor-in-chief of Phlebology Journal, and he has a wonderful companion in life, and also students who speak for themselves in terms of quality in science and human beings. So Professor Davis will wrap up for us the take-home messages, and then I will welcome Willie and Oscar to give some final remarks.
Well, thank you very much for the privilege of being allowed to sort of finish off and round up this great session. Obviously, everybody knows Fyodor and Peter very well, and they all spoke very intently, but I'd just like to take each one in turn and just sort of make some generalized comments. Obviously, I think that a lot of people were expecting the revision of the CEAP classification, and it's obviously been a 20-30-year project with various people involved. I think the most important thing is, and Fyodor highlighted it, but I think the one thing we have to really emphasize to people, that it is not a measure of severity, and it should not be used as a way of judging how treatments are going as a rule. So I think it's very important that is very clear to everybody. Fyodor mentioned then a physician reported outcome measure, the VCSS, which again was instituted by the AVF and is a very good tool that's used around the world. But again, it does allow some bias, because it is a physicianly reported tool. And I think hopefully in some more of these future meetings, there will be some more discussion about the importance of patient-reported outcomes, because I think they are important. The one thing I think that is important and to also note is that you should not, in my opinion, and certainly it was NICE's opinion as well, that you should not use the CEAP classification as a tool for rationing healthcare. And I think we would all agree with that. And the key thing should be intervention to patients who are symptomatic. I would maybe lay down the gauntlet slightly to Fyodor, and it was mentioned earlier on, that I think it's a shame that this opportunity to incorporate either phlebitis or bleeding into the CEAP classification was not taken, but hopefully maybe we could see an earlier revision, maybe in the next year or so. Peter, as usual, gave a fantastic talk about the role of guidelines, and Peter obviously knows that one of my hobby horses is actually we should more or less all be trying to develop guidelines with respect to the AGREE format. But I think for any of you who are going out to develop guidelines with respect to the AGREE format, can I please emphasize to you the importance of having patients and other individuals, and depending on the guideline, you might even want to have carers involved, and that is really of great importance so that you get some widespread involvement. And undoubtedly, editorial independence is important. Again, you wouldn't be surprised that I think it is important that you look at cost effectiveness. And as Peter asked me to comment on cost effectiveness, if you look at the world literature on the cost effectiveness of disease processes of all types, not just veins, you would be amazed how many countries actually have data on how much of their GDP they want to spend on healthcare and how much is spent in treating various disease states. And I would commend to you that while cost effectiveness should not be the only arbiter, but it is a very important arbiter if you want to deliver healthcare equitably to your population. I commend the AVF on looking at the appropriateness of interventions. I think this is a key problem. I think it is probably a key problem anywhere in the world, but also where you have people who are being paid for items of service as opposed to being salaried, to look at appropriateness is probably key. Peter talked about the various guidelines. Now, I would comment about the NICE guidance, that the NICE guidance, all the interrogation of the data is actually done by non-specialists, non-clinicians. And I can assure you that when you're sitting chairing a meeting and somebody takes one of your papers or one of your colleagues' papers and tells you that actually it's rubbish, does actually make you listen and think. And the other thing that it should be noted that the average NICE guidance takes about a year to do and costs on average £500,000 to develop, because it is done with the non-involvement of any societies. So, ladies and gentlemen, first of all, there are many people who need to be thanked. I'd very much like to thank Sergio very much for giving me the opportunity to talk. And I'm sure on behalf of all of us who listened, we'd very much like to thank Fyodor and Peter for kicking off this venture. And I'm sure, Sergio, we all look forward to spending many Sunday evenings for us in the UK, listening and seeing all our friends around the world. Thank you very much for the opportunity.
Thank you so much, Prof. Couldn't I be like more like a director of the orchestra? Thank you so much once again. So I will share my screen once again because we are coming to the end. So we will go back to not just the fun part of our group, but also the serious part. So I like Oscar to make a final remark in 1 minute on the scientific part. Oscar?
Yes, good job, Sergio. Good coordination. Well, I would like to mention just 3 points. The first is that we realize the importance of continued education developed in a global network. The other one is that it's not just about evidence-based, but also on how we applied it, in particular in the different national reality. So global, but also with an eye on the national needs. The last one is that all the different discussion from the different continents provide so-valuable perspective, making us thinking we truly need to be all together, co-working scientifically in a proper direction. Even better if with our humanitarian support as today, since first of all, we are physicians who dedicate their lives to patient and humankind support. Again, I look forward to be all together in a person in Buenos Aires to next April meeting. Thank you all.
Thank you, Oscar. Willie, you are the only one who can close in 30 seconds because we have to close.
All right. Well, thank you all. Thank you all the attendees and speakers. Thank you, Peter and Fedor, for the wonderful presentation. I think that everybody had touched on that. I think that the main thing about consensus documentation and guideline is that not all the nations and continents start at the same footing and the same level. I think that that's something that we need to sort of keep in mind. Differences in population, disease, epidemiology, and then obviously socioeconomic issue. But one thing I want to really emphasizes the importance of education, because only education through entities like the UIP, like the IUA, obviously Oscar is on there, and then Dr. Mastella, again, Dr. Davis, Peter and Fedor. I think that we all need to focus on this part, because education is the only way that I could think of to limit or to minimize this gap between continents and nations, so that guidelines will become more and more beneficial to the global population in treating any type of disease, but particular venous disease. Thank you all.
So thank you so much, everybody. We just looked at the program that we will have for next Sunday on ultrasound assessing. Once again, thank you, everybody, for supporting this initiative, in particular to the stellar faculty who has made this possible. And we look forward for seeing you next Sunday, and at the same time, also on the educational platform where you can enjoy all the recorded video lessons. It's 5:30, so it's time to go enjoying the rest of the Sunday. Thank you so much, everybody.
Ciao.
Ciao.